My goal is to cover an approach to evaluating arthritis films and then to talk about specific entities where the arthropathy may present as either a sports medicine injury, a tumor, or infection. So when I'm approaching arthritis, I'm usually fitting them into one of three categories. Those that are purely productive with no erosions like osteoarthritis, those that are purely erosive with no bone productive changes like rheumatoid, or those that have both a component of erosion and bone production like the seronegative arthropathies or erosive osteoarthritis. We'll come back to the primary features of erosion, bone production, and disease distribution, but I wanted to spend just a few minutes talking about some of the accessory findings that can help us identify arthropathy. One of the first one is soft tissue abnormalities. A lot of times with active inflammation, we can see fusiform soft tissue swelling around an inflammatory joint, here seen at the third proximal interphalangeal joint. This is most commonly seen with rheumatoid, but can be seen with any of the inflammatory arthritises. Occasionally, there's a specific type of soft tissue swelling that may be seen where it takes on the form of a sausage, like a hot dog or cocktail sausage, and it's called a sausage digit. This is most often seen with diseases like psoriatic arthritis, here in a patient with pretty extensive erosive changes in both distal interphalangeal joints and a little bit along the proximal interphalangeal joint margin. But another variant of soft tissue change that can be very helpful is a lumpy, bumpy, kind of eccentric deposition or nodular type of appearance. This happens when there's a deposition of substances under the soft tissues. We most often see it with gout, but it can be seen with a variety of abnormalities. Here also seen in sarcoid, where we have the classic lace-like trabecular pattern. Occasionally, the abnormality of the soft tissues is soft tissue loss. In a normal situation, when we look at the soft tissue thickness over the tip of a finger, we expect it to be more than half the diameter of the diaphysis of the adjacent phalanx. And here, in this patient, we see that there's soft tissue loss at the tips of all of the fingers. This is pretty classically seen with scleroderma or crest syndrome, but it can be seen with a variety of abnormalities. So in addition to soft tissue swelling or loss, we like to look for mineralization. Sometimes it's the source of the symptoms. There's a couple different patterns that we classically see. Here within the triangular fibrocartilage disc, we see stippled mineralization, seeing some of it also within the lunotriquetral and scapholunate ligament, a little bit within the capsule, and it's very classic for calcium pyrophosphate deposition appearance. Another pattern that we may see is this globular amorphous blobs of mineralization here in a rotator cuff tendon, pretty classic for hydroxyapatite deposition. Occasionally, these lumpy bumpy depositions, especially gout tophus, may have varying degrees of calcification within it that can increase the density. The other pattern that I'm going to look for is how the joint space is narrowing. We're pretty used to seeing osteoarthritis where it causes this asymmetric joint space narrowing. Here we see along the ulnar aspect of the joint it's narrower than it is along the radial. So varying degrees of asymmetric joint space loss at all the joints, creating subluxations and angulations of the phalanges. And the knee, we're seeing a varus angulation related to medial greater than lateral joint space loss. Hip, very often the osteoarthritis will cause a supralateral joint space loss that's asymmetric from the medial joint space. Occasionally, however, the joint space loss is uniform, and this is much more reflective of infectious or inflammatory causes that are activating cytokines and collagenases that are removing the cartilage from the surface. So when we look at a normal joint, it looks like the subchondral bone plates have moved together because the cartilage intervening has been removed. Here in a patient with a fight bite injury, an infection at the third metacarpophalangeal joint. Here in all of the metacarpophalangeal joints in a patient with rheumatoid arthritis. That same process can be seen in other joints. Many times when we see joint space narrowing in the knee or the hip, the typical go-to is to think that this is automatically osteoarthritis. And we do have some marginal osteophytes at the patella. But if you look at all these joints, the joint spaces have uniform joint space narrowing with pretty minimal bone formation, marginal osteophytes. And this is a patient with rheumatoid arthritis. We see a large joint effusion, and likely a good portion of that it would be synovitis. So We're going to pay attention to the soft tissue swelling, soft tissue mineralization, whether the joint space narrowing is symmetric or non-symmetric. But the key features that I started off with that we're going to go searching for are whether there's erosions or bone production. So let's take a look at those. So when erosive arthropathy is active, it will begin to uniformly remove cartilage from the joint. The areas where there are bare areas of subchondral bone exposed to the joint space, or where the cartilage is the thinnest, are the first locations where erosions will appear, as we're seeing here along the dorsum of the third metacarpal head and somewhat within the phalange. The other thing that may be seen is something that's referred to as a dot dash pattern, so that the bare area and the thin areas of cartilage have been removed. If we look here at a normal cortical margin, we see that it has this thin white line that could be drawn with a number 2 pencil, whereas along the margins of this metacarpal head, we see that the bone has been started to be removed. We've changed the contour. We're losing some of the bone margin along the dorsal aspect, and it's because it's early erosive changes. As the cartilage is completely removed from the joint surfaces, the joint margins settle together, and the erosions may begin to appear on the central portions of the joint. All of these in patients with rheumatoid arthritis, and you'll notice that none of them have much in the way of secondary osteoarthritis formation. Some erosions naturally produce bone. Here are marginal erosions at a distal interphalangeal joint. If you take a step back, you'll see that there's a sausage-like swelling throughout the distal aspect of this finger. We see marginal erosions at the distal interphalangeal joint, and if you look at the bone contour in comparison to the more normal joint adjacent to it, we see that we have additional bone formation, even a little bit of periosteal bone formation or enthesitis at the margins of the middle phalanx. Pretty classic for a peripheral spondyloarthropathy. Here, an even more exaggerated appearance where there's the proliferative bone formation adjacent to the erosions, where the bone formation is whiskery, new proliferative bone formation at the margins, and you can see a more normal contour to a joint as a comparison of this extra bone formation. And this is all very classic for psoriatic arthropathy. Contrast that with the erosions seen in erosive osteoarthritis. Here we have joint space narrowing at the interphalangeal joints, a little bit asymmetric. It's got some angulation of the joints. We even have an ankylosed joint from productive bone changes across. We have these central erosions in the distal interphalangeal joint of the third finger, here at the proximal interphalangeal joint, a little bit here in the distal interphalangeal joint. And if you look at the contour, it takes on appearance of how children draw seagulls. So it's referred to as a seagull type of erosion, very classic for erosive osteoarthritis. So the other feature that will help us is the distribution of disease. So when I'm dealing with an erosive arthropathy, the first thing I start doing is going through and looking at all the joints that are involved. If we have a single joint involved, the diagnosis of exclusion has to be infection. Now it may end up being that it's being caused by a crystalline arthropathy, PVNS, or synovial chondromatosis. When a few joints are involved, the seronegative arthropathies like psoriatic or reactive are more common, but also may be seen with gout, where periarticular erosions are more common than intraarticular. And then when it's at a bunch of joints, then the distribution can be very helpful. When we're looking at hand and foot films, which joints are involved is the first thing that I go looking for. And one of the first places my eye is drawn when there's erosive arthropathy is to the distal interphalangeal joints. And the reason is, you'll notice that the one diagnosis that's not listed on the distal interphalangeal joint is the rheumatoid arthritis. Rheumatoid virtually never occurs at the distal interphalangeal joint. So if I have an erosive arthropathy, say in the wrist or the metacarpophalangeal joints where multiple joints are involved, I go up and look at the distal interphalangeal joints. If there's erosive changes at the distal interphalangeal joints, it's much more likely to be one of the seronegative spondyloarthropathies, like psoriatic or reactive. Now I'm going to spend just a few minutes covering specific arthropathies. What I wanted to start with is osteoarthritis and just mention what the diagnostic criteria are. Asymmetric joint space loss, osteophytes, and subchondral sclerosis. They may have cyst associated with it. It should be non-erosive. The thing to point out is there's a normal distribution. We're used to seeing it in the hips and knees potentially in the shoulders, happens in patients in older age. We don't expect to see it in patients under 45 years of age. If we're seeing it in an atypical distribution or at an atypical age, then we want to think about it and say, is it because it's post-traumatic? If there isn't a history of prior injury to the joint, then one of the other things to do is think about other diseases that may create appearance of osteoarthritis but in an atypical distribution. One of the more common ones is calcium pyrophosphate deposition arthropathy. So here we have a patient who's got pretty extensive chondrocalcinosis in the menisci. The medial and lateral compartment joint spaces are not narrowed. We have a little bit of osteophyte formation in the medial compartment, but if you look at the patellofemoral compartment, it's completely obliterated. And I know that because I'm also seeing the typical erosion of the distal femoral metadiaphysis from when the patella slides up there. This is a pretty classic appearance for CPPD arthropathy of the knee, where it favors the patellofemoral joint. Here's another patient where the medial and lateral compartments aren't narrowed, but we have marked patellofemoral joint space narrowing and the chronic remodeling of the distal femur. CPPD arthropathy is also pretty common in the hand and wrist. So again, I showed you this case earlier where we have mineralization in the triangular fibrocartilage and the ligaments, but one of the appearances that may be caused by CPPD arthropathy is a slack wrist, scapholunate advanced collapse, where the capitolunate and capitoscaphoid joint space may be markedly narrowed and the scaphoid might even start to erode or remodel the distal radial surface, a lot of times with the scapholunate interval widening and the capitate migrating in between the two. Here we have what looks like a more typical distribution of osteoarthritis, severe basal joint of thumb, triscaphy joint being involved, all which could be part of a normal osteoarthritis. We see calcium pyrophosphate deposition in a lot of soft tissue structures and might see it in the capsules of the hand. One place that we go to look for CPPD arthropathy in the hand is the metacarpophalangeal joint. So the typical osteoarthritis distribution in the hands is in the distal and proximal interphalangeal joints, the interphalangeal joint of the thumb, the first metacarpophalangeal joint potentially, and the basal joint of thumb and triscaphy joint. But we don't expect osteoarthritis typically in the remainder of the metacarpophalangeal joint. So second, third metacarpophalangeal joint here with some calcium pyrophosphate deposition seen in the soft tissues. Notice the large beak osteophyte. Now they still have asymmetric joint space loss, subchondral sclerosis, and osteophyte formation. What looks like OA, but it's in an atypical distribution. You'd ask if this patient did a lot of manual labor. Are they a jackhammer operator? The other consideration would be for a CPPD arthropathy. Sometimes CPPD arthropathy will present an appearance such as other disease processes. In this case, taking on a really severe osteoarthritis may mimic a neuropathic joint. Here's a patient where there's clear chondrocalcinosis in the hyaline cartilage of the right hip and some joint space narrowing and osteophytes, but the contralateral hip has areas where the acetabular roof and superior femoral head are fragmenting. And sometimes it can be much more progressive than this and look like neuropathic or an infected joint related to crystal disease. Same thing can happen in the spine, where it can take on a severe degenerative or neuropathic type of appearance here in a patient with CPPD within the disc, material extruding from the lateral margin. One clearly identified cause of DINS fractures in older patients is CPPD, where no trauma or minor trauma can result in a fracture, type 2 fracture most commonly through the DINS, from deposition disease around the DINS, creating erosions and an easy means of fracture of the DINS. So if you're seeing OA in an atypical distribution, you're going to think about CPPD. The other one that I want you to think about is hemochromatosis. Here we have a patient who's young, has pretty healthy looking joints everywhere except for at the metacarpophalangeal joints, a typical distribution for hemochromatosis arthropathy. Notice it looks like osteoarthritis, asymmetric joint space loss, osteophyte formation, component of sclerosis. We're seeing it bilateral and symmetric. No chondrocalcinosis seen in any of the soft tissues. So it looks like osteoarthritis, but it's at a young age. You'd ask about an occupational injury, manual labor type of job. But if you're not seeing that, think about hemochromatosis. It typically becomes clinically apparent somewhere in the 30 to 50 year age range. Most of them will develop some type of arthritis. In fact, many of them, that's their presenting symptom, and they may have been seeking medical attention for joint pain for some time prior to getting diagnosed. If you consider it, if you're seeing that pattern of presentation, order a serum transferrin saturation test. It's looking for high iron content as a finding for making the early diagnosis, or at least screening for hemochromatosis, and then it can be referred on to endocrine. The whole goal is to prevent them from developing the secondary consequences. Here we have a black liver on a T2 sequence because of the marked amount of iron deposition both in the liver, here also within the pancreas. And what that leads to is cirrhosis, and here in a patient with ascites and even a secondary hepatocellular carcinoma. So we'd like to diagnose this and get them on treatment prior to having the secondary effects. So the next disease I'd like to talk about is rheumatoid. Should be purely erosive with no bone productive changes. Sometimes after the joint has been eroded or the cartilage has been eroded away for a long time, they may develop secondary osteoarthritis on top of it. It tends to be bilateral and symmetric. Here's a typical distribution. We're seeing pancarpal joint space loss in both wrists, some erosive changes. We have metacarpal phalangeal joint space loss, no distal interphalangeal joint involvement. When we look at the metacarpal phalangeal joints, we actually get to see some of the erosions in profile, so we know that they're not just cysts. Same thing at the ulna. Here, pancarpal joint space loss, another patient with rheumatoid. Little bit of erosive changes at the intercarpal ligament attachment. Typical distribution, bilateral symmetric in the wrist. This obviously is not going to be your problem. It's going to get referred on to rheumatology until they start having some complication of their rheumatoid that may get them back in your clinic. When we see that symmetric joint space loss in the hips, it leads to the hip migrating axially towards the spine. Notice the bone is completely eroded away. There's not a lot of osteophyte formation on this hip joint. You've seen this one already in the knee. Symmetric joint space loss, not a lot of osteophyte formation. It's all classic for rheumatoid. Common location to get it is in the elbow. Symmetric joint space loss. Erosions, huge amount of synovitis and joint effusion causing fat pad signs. These will progress, and a lot of times you're seeing them for getting total elbow replacements because of their marked arthropathy. The rheumatoid arthritis frequently will lead to rotator cuff tendon tears. Here in a patient with chronic full thickness rotator cuff tear, see markedly eroded and remodeled glenohumeral joint, but we also have erosion at the acromioclavicular joint, which is very common. If you end up with an MR looking for rotator cuff tear, you might see these unusual flecks of proteinaceous debris within the joint, what's been referred to as rice bodies. If you give contrast, these won't enhance. They're not synovitis, they're debris that's floating around in the joint. Where rheumatoid might end up in your clinic unsuspected is when it has an atypical presentation. Occasionally it may present in one or a few large joints. So it may be that knee coming in with chronic knee joint effusion and pain that may be mimicking a meniscal tear or other internal pathology. It may be something like this case where you have this marked tenosynovitis of the flexor tendons of the wrist. When I see this pattern, I'm thinking rheumatoid or potentially mycobacterial infection. Here's a case that was referred into our orthopedic oncologist for a lytic lesion in the proximal humeral metadiaphysis. It's got non-sclerotic margin, so it's a 1B type of margin. At this patient's age of 68, you have to think about Mets, myeloma, potentially lymphoma. But if you look at the glenohumeral joint and you look at the acromioclavicular joint, you're seeing a lot of erosive change, an eroded and widened joint. Get an MRI, and we find out that this lytic lesion is actually produced from a synovial cyst extending down the medullary space. And I have seen these in the knee look like giant cell tumors and extending in the soft tissues as large cystic masses. When you look at this joint and see all of the inflammation, the marked erosive changes and synovitis, it almost looks like an infected joint. And I'm sure that's one of the things that we were aspirating it for to make sure that it wasn't secondarily infected. The other frequent referral is for rheumatoid nodules. Now, they often will occur along the extensor surface at the elbow, So it's one of the main items in a differential for a lobular olecranon mass. Notice that the elbow joint has symmetric joint space loss. This one has some secondary osteoarthritis. These rheumatoid nodules can even cause lung nodules. So you may be getting a chest x-ray on a patient pre-op and see cavitary pulmonary nodules that look like METs or squamous malignancy. And these are common with rheumatoid nodules. They'll light up on PET scan because they are inflammatory. So a lot of times it requires needle biopsy to diagnose it. Here's one at the heel. You can see that there's marked inflammatory changes around the hind foot from rheumatoid arthritis involving the subtalar and talonavicular joint, but this person has a classic rheumatoid nodule. So the last of the topics that I'm going to talk about for the arthropathies really is the axial spondyloarthropathy. So this one's in the erosive plus productive category. So the prototypical one for the axial involvement, meaning that it's involving the spine and the sacroiliac joints, is ankylosing spondylitis. When it involves the sacroiliac joints, and most of the time if it's got axial involvement, an axial spondyloarthropathy, the sacroiliac joints will be involved. It happens first at the anterior 2/3, and that's because the posterior aspect of the joint is fibrous ligamentous, and the hyaline cartilage synovialized portion of the joint is more the anterior aspect of the joint. Look at the shape of the sacrum. It's shaped kind of like a keystone on axial, where the anterior joint line is going to be more lateral than the posterior joint line. In this case, they're just about over projecting each other, so not making my point, but I'm using this as a normal comparison, so I want you to see what a normal SI joint looks like. Look at the margin of the joint. First of all, the joint is a pretty smooth, undulating contour. The other is that the bone margin right up against the edge of the joint is a sharp white line. You can see part of the other, probably part of the anterior joint line out here. Same thing, we've got joint line, but you can see that it's a nice smooth white line and a smooth undulating joint. Compare that with this patient with ankylosing spondylitis where there's bilateral symmetric erosive disease. The white line is gone because we have a huge amount of osteitis surrounding the joint that's creating a lot of white all the way around the joint. And then look at the joint itself. No longer that smooth undulating, but it's got this beaded appearance from erosive changes on both sides of the joint. It will start worse along the iliac side of the joint, but you'll see this irregularity in osteitis. So contrasting normal with ankylosing spondylitis. Occasionally we'll end up picking it up first on an MRI being done for some other reason. Either joint pain, pelvic pain, hip pain, where we get whole screening images of the pelvis, and we'll see marrow edema-like lesions on both sides of the sacroiliac joints. Here on a coronal image, getting to see it on both sides of the joint with the intermediate T1 signal replacement of the joint from active inflammation. And the inflammatory changes on the MR will predate the radiographic findings. The other thing that might get mistaken for an axial spondyloarthritis is osteitis condensans. That's more a sclerosis related to a component of instability in the joint. The typical appearance of it is worse along the iliac side, usually at the lower portion has this cell-shaped or rounded area. We have a little bit more extensive osteitis condensans in this patient, even some along the sacral side. Contrast that again with ankylosing spondylitis. When we put them side by side, notice on our osteitis condensans we still have the smooth undulating joint line. It may have white up against it because of the osteitis, but there's no erosive changes along the joint, in contrast to the erosive changes associated with ankylosing spondylitis. With ankylosing spondylitis or the axial spondyloarthropathies, a variety of changes may be seen in the spine. Here's a classic one of squaring of the vertebral bodies. Because of the osteitis that's produced, or I should say the enthesitis that's produced under the anterior longitudinal ligament, the vertebral bodies can lay down additional bone along the front where the anterior longitudinal ligament is and take on this abnormal square front instead of having their normal concavity. This one's also beginning to form just a touch of syndesmophytes where there's some ossification from enthesitis and Sharpie's fibers of the annulus fibrosus attachments. And the other finding that you might see is something that's referred to as shiny corners, where you get this white at the edge of corners. That inflammatory process that's happening along the annulus fibrosus and the entheses incites an osteitis in the vertebral body, which is seen as these white corners that we refer to as shiny corners, also known as Romanus lesions. So over time, as the inflammatory process heals, the body will lay down ossification and create what's been referred to as a bamboo spine. It really does look like bamboo. But it's not just involving here along the entheses, but we see that the synovial joints, the facets, have all ankylosed, and the interspinous ligaments have had an enthesitis and fused into a solid bone. That creates some of the other findings that have received names off of the AP view, which is like the trolley track sign, where the fused facet joints create this paralleling band of track, as well as the dagger sign from the white band going down the middle from the fused spinous processes. The spondyloarthropathies, when they occur atypically, say in a large joint, causes the same enthesitis where we see thickening and increased signal in the patella tendon that enhances. We see a synovial enhancement in this patient, replacing a lot of Hoffa's fat, synovial enhancement in all the white areas here in this post-GAD image, and even a little bit of marrow edema. So all these are inflammatory changes that could bring a patient in for knee pain. That same enthesitis can be seen just about anywhere in the body where the tendons attach. Here we see a really pronounced amount of enthesiopathy where the long plantar ligament, and again, where less impressively where the plantar fascia attaches on the heel, maybe a little bit where the Achilles had some issues. We commonly see enthesiopathy here, but we currently have a ton of active inflammation at both the plantar fascia and long plantar ligament attachments on the heel, creating marrow edema-like signal. So the other thing that we come across really frequently is crystal deposition disease. It's pretty much a joke in our reading room that just about anything could be gout. And so gout is definitely on the rise. When it comes in as a typical presentation, it's probably not that hard to make the diagnosis. It doesn't always have a classic tophus or erosion that we can see radiographically, but they'll come in with the swelling, the pain. It'll be in the right age group. We can check a uric acid level and see if it's elevated, but a lot of times it's a rate-limiting disease that will go away in about 7 to 10 days and responds well to steroids. What we're looking for when we are trying to see it radiographically again is to see lumpy, bumpy soft tissue, potentially with a component of mineralization in it, and periarticular erosive changes without joint space narrowing. The joint spaces are preserved because the tophus is actually outside the joint. Here again, big erosion. Here's a lump of tophus. We have erosive changes more distally, but if you look at the joint spaces are not narrowed. Even though it's taking out a big periarticular erosion, the rest of the joint is preserved. Same thing in the foot. Classic location at the first metatarsophalangeal joint. It almost looks like a cyst. Joint space is preserved. You'd have to get it in profile to prove that it's an erosion. Same thing at the fifth. I'll point down here that we have it at this first metatarsophalangeal joint as an erosion with the joint space preserved. Nice sclerotically marginated erosion, all classic for gout. Gout loves the midfoot. And what it looks like on MR is that gout deposits tend to be very black on these T2 sequences. We're used to going to T2 usually as our pathology sequence and seeing all the pathology as being bright, but don't expect that with deposition diseases like gout, where it's very black substance creating an erosion in the adjacent first metatarsal head. Now, shockingly, we are starting to see gout in just about everywhere in the body. In this person, it was coming in as a clicking mass that was mimicking a meniscal tear, but if you look, there's calcifications all over the place. We'll have them in portions of our popliteus tendon, various tendons of the semimembranosus, and our biceps femoris tendon. We even have it intra-articularly in portions of the PCL ligament. We frequently will see it in the distal quadriceps tendon, here radiographically as a lumpy mass with partial mineralization, frequently with a component of erosion associated with it. Seen here, this one's not as mineralized in the soft tissues, but we get to see the erosion with some inflammatory changes around it. All very classic for gout. In fact, it's one of the things that may produce a fracture from eroding the bone. Like rheumatoid nodules, gout is in the differential for a electronon-bursal enlargement. And when it does break into the joint space, it can produce some pretty unusual appearances of sometimes large cystic changes that may look like a hemophilia or some type of bone tumor. Now, interestingly, when you CT these, you can start to see the mineralization, and you don't know specifically whether this is some type of CPPD arthropathy because it looks stippled. But one of the things that we can do to try to confirm the diagnosis when we have it in an unusual position is do a dual energy CT. This is a reconstructed image from a dual energy CT, and because uric acid crystals will absorb radiation at a different level than other crystals, we can look for the absorption of the crystals and paint a pattern of where there's deposition of gout. Another is hydroxyapatite deposition. This probably makes up 20 to 40% of shoulder pain in patients over 50. At least that's the reported number. We pretty commonly see it in the rotator cuff tendons, big amorphous blob of mineralization. When it breaks out of the tendon into adjacent tissues, it creates quite an impressive periarthritis. Here we're seeing a lot of bursitis in the subacromial subdeltoid bursa from hydroxyapatite deposition extension. One of the things that can happen with this hydroxyapatite is it can actually erode into the bone from the tendon that it's in and can present like a soft tissue or bone mass. It can induce periostitis. In this case, we have what looks like a lytic lesion with a calcified nidus. Looks all the world like an osteoid osteoma. But when you follow it on a series of images, you see that that mineralization is coming out into the teres minor tendon. And this is intra-articular extension of hydroxyapatite deposition. If you get an MR, because the hat is very inflammatory, you can see what looks like marrow replacement. So it can mimic a bone tumor, or in this case it was looking more like an osteoid osteoma with edema and inflammation around it. Sometimes it'll induce an osteitis once it's eroded into bone. We get to see a little bit of hydroxyapatite up here, but we had this sclerotic bone lesion that was being compared with the sclerotic bone lesion seen on the MRI. Notice the inflammatory changes around it. Not a lot of primary bone tumors have edema around them. You'll see it with osteoid osteomas and osteoblastomas. You'll see it with chondroblastomas. Not a lot of other tumors will do that, not even metastases. So when we're seeing that and it's in line with the tendon, we have to think about hydroxyapatite deposition. Rotator cuff tendon is a very common site, so is the pec major. Here's another case where there's this lytic lesion, has a focus of mineralization, almost looks like a chondroid lesion. Is it a juxtacortical chondroma or a periosteal chondroma? Is this some type of small Brody's abscess, subperiosteal Brody's abscess with an extruded sequestrum? All of those things would be in consideration for this. This is just hydroxyapatite deposition starting to erode in the bone. Another place that I see it that's often the bane of my existence is around the hip. It loves to be at the distal glute max region like we're seeing it here. It can induce another calcific periarthritis like we're seeing, where there's inflammation around that big blob of black at where the glute max tendon is coming down onto the linea aspera. And this inflammatory response can raise the ESR and can raise the white blood cell count, and because they're coming in with hip pain, usually in the middle of the night, it will present like a septic hip. It loves to be around the knee. Here in the fibular collateral ligament, portions of the popliteal tendons will often involve it. Here in the medial collateral ligament, where it's inducing an inflammatory response. Here in the retropharyngeal portion of the spine and the longus colli muscle, you can see the soft tissue swelling anterior to it, throat pain, globular area of mineralization in the muscle. And again, it'll raise white count and can raise all the concerns for being infection. The other thing that can happen is that instead of breaking into the bone or into a bursa, it can actually extend into the joint and can cause a rapidly destructive arthropathy that can look all the world like infection or a neuropathic joint. From initial to 2 years later, we see this large joint effusion with mineralization, severe joint space loss. So our general take on this is when we have this pattern and we're thinking, is this a rotator cuff arthropathy, neuropathic joint? We look at and think in an older woman with a large effusion and crystals along the margin of the joint that's coming in with this arthritis and rotator cuff tear, one of the things we want to think about is Milwaukee shoulder. Occasionally CPPD will do the same thing. It will break into the joint and will incite an inflammatory response that can look all the world like a septic joint, a monoarticular process. Where here we're seeing erosive changes and marked joint space loss, the synovitis, inflammatory changes, and erosions all associated with it. And a lot of times we'll have to aspirate in order to make sure that this isn't some septic arthritis that's spreading from the distal radial ulnar joint, radiocarpal joint, midcarpal row. A rare presentation of pseudogout is tophaceous pseudogout. This case came in with this mineralizing mass along the posterior aspect of the knee joint. On MR, it was low signal. We were wondering if this was a synovial chondromatosis. When they got in and scoped, they were seeing these chalky masses, which had rhomboid crystals when looked at under our microscopy, turned out to be tophaceous pseudogout. The other things that may present as a mass-like arthropathy is pigmented villonodular synovitis and synovial chondromatosis, both of which usually are seen in only one joint. So PVNS may present with chronic swelling and pain. In the knee is one of the locations that it may present as a focal mass that looks something like the pseudogout that we were just looking at, the tophaceous pseudogout, as an isolated mass within the knee. Most of the joints, when they're involved, it will have diffuse involvement. What we're looking for is lobular joint effusion with a soft tissue mass. Notice that there's no calcifications. It's one of the distinguishing features radiographically from synovial chondromatosis. On T1 sequence, we see that the synovium's thickened, and notice the signal of the synovium is black. Here on PD sequence, the synovium again has black areas within it. Not a lot of things are dark on both T1 and T2. That takes us to thinking about things that are densely mineralized, but we've seen the radiographs and this isn't mineralized, or things with hemosiderin with them in them. So in this case, this is from the hemosiderin from diffuse PVNS throughout the knee. Here, a case with a focal PVNS. The other mass-like process that you'll frequently come across is synovial chondromatosis, where they'll develop multiple chondroid or osteochondral bodies. Here we see lobular mineralization, big joint effusion, lobular mineralization all along the posterior aspect of the joint. Pretty typical for chondroid type mineralization. Sometimes the mineralization is pretty faint. Here we have this band of faintly mineralized bodies along the recess of the head-neck junction and extending up along the medial joint line with a few lower down as little mineralized bodies within the joint. Can faintly see these same bodies on CT and having created scalloped out erosive changes of the femoral neck. Occasionally the bodies are well mineralized. This is a gratuitous case of marked synovial osteochondromatosis of the shoulder, where we can see bodies crammed into every recess and down the biceps tendon sheath that are low on T1 and low on T2 because of the mineralization. Here, faintly mineralized bodies along the knee with chondroid material seen along the margins of the joint. So key principles when you're approaching an arthropathy. Obviously, if you have disease process on both sides of the joint, you're probably dealing with an arthropathy. But keep an open mind, because occasionally other disease processes will mimic an arthropathy. If you're dealing with a solitary joint of involvement, the diagnosis of exclusion is infection. If it turns out to be a crystalline arthropathy, fine, but we're going to make sure that it's not infection. If you're seeing uniform joint space loss, think of inflammatory or infectious diseases. Ask about inflammatory symptoms. Erosions plus proliferative bone formation adjacent to them, is classic for the spondyloarthropathies, any of the HLA-B27 associated ones, ankylosing spondylitis, psoriatic, reactive, inflammatory, bowel-related, all fall into that category. And gout is on the rise. So gout is a very common abnormality, and it's likely to see unusual presentations of it because of how frequent it's present. So I'm just going to put a couple cases in here, something for you to step up and test your skills. First thing that I want to remind you of is keep an open mind. Before you approach any case, make sure that you really think it's an arthropathy. Think about all categories of disease. Once you get to the point that it is an arthropathy, look at the type of soft tissue changes, if there are any, see if there's any mineralization. Look at the pattern of joint space loss. Is it symmetric or asymmetric? And then look for erosions. Look for bone productive changes. Is it just osteophytes like reparative bone? Or is it proliferative bone, that whiskery periostitis, enthesitis that can happen along the margins of erosions? Look at the distribution of disease, especially in the hands. See if it's typical or atypical for what you're expecting for the disease process. So here's case number 1.